Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
.com. Of course, everything's .com. Okay, it looks like, I'm looking out through our radio today, Doc, and it looks like our good little boys and girls that came to our class last week did a good job. Whether you're little kids or grandpas or grandmas, we're actually, this is part 2 of a 2-part program. And what we're talking about are the 6 classes of venous disease. And everybody falls somewhere in this chart. And that's why we're having such a good time explaining these things to you. And it really comes after a lot of people in Doc's profession got together and said, we have to standardize things so we can treat people. We can telegraph information and we can identify courses of treatment and all kinds of things for patients of venous diseases. So we learned about 3 out of the 6 last time. And if you missed it, well, that's no problem because we'll let you go to the website and catch it on a podcast. veinclinicsofhawaii.com. Anyway, if you were with us last week, welcome back. It's been a week, and now you're going to sit down and learn about the other 3 classes. We talked about the first 3 from a little thing called spider veins all the way up to swelling, and this week we're going to talk about this disease as it progresses. Once again, Dr. Jula, please explain what CEAP means.
Yeah, well, that is, as we started to talk about last week, it's a classification system that has been developed over the past 20 years or so within the world of vein treatment and something that we call phlebology. And and it's a way that we can kind of verbalize how severe a patient's venous disease is. And we talked about the fact that we call it the Seep Classification because there's 4 different parts of it, and the letters CEAP, they stand for clinical, etiology, anatomic, and pathophysiology. Well, the one that we use the most is the clinical part of it, and that's what we've been talking about. There's 6 clinical levels of different patients and how they present, how they look, what their examination tells us, what they verbally tell us when they come in and we take a history and do a physical examination. So anyway, it sort of corresponds to how severe their disease is.
Have you determined that you develop a certain level of peace when you find out what you have, what is your disease, and at what stage is it? I mean, everybody, I think, we talked about this last time, everybody knows there are 4 stages of cancer, 1, 2, 3, and 4. If you're in 4th stage of cancer, you're in pretty big trouble. And the same thing sort of goes through with what we're talking about, these 6 classifications. But it's not exactly numerically a division of 1/6 each time, is it?
No, it's not.
Yeah, with respect on how many people actually get affected, because everybody has stage 1, be a little spider vein. But not everybody gets a big leg ulcer, which we're going to talk about later, right?
Yeah, you're right. That you could sort of look at it like that because there's so many people out there with spider veins that it probably is 80 or 90% of the population. And then actually there's actually something called C0, and those are people who have no physical findings.
Boy, I got to find one of them. I got to I got to hope that it rubs off. I want to find a cousin or something.
Yeah.
But it is interesting because there's one thing, and gang, we got a lot to cover, so I don't want to interrupt Doc too much. But I do want to tell you is that we are living, thanks to medicine, and we're living a lot longer than we used to. And so it stands to reason that this heart and this circulatory system that we have, it probably wasn't designed to run forever. And we are outliving some of our other parts. So it would seem that if you have this disease, hereditarily or not, that you need to, as you get older, find out what stage you're at and how to sort of unslippery the slope, if you know what I mean.
Yeah. And there are negative repercussions that can happen from venous disease if it's bad enough and if it goes untreated. So I usually tell everybody that it's a part of general health maintenance because of the fact that venous insufficiency and venous disease of one sort or another is so common in this, especially in this population, that if you have symptoms or if you have any indication that you might have a vein problem, it behooves you to kind of be evaluated, figured out, and do something about it, even if it's something as simple as wearing compression stockings more often. But sometimes very easy things can make a big difference. But so anyway, there's a clinical part of the classification. There's etiology. In that, like we talked about last week, primary, secondary, and congenital, and it has to do with what brought it on. Most people have what we call primary venous insufficiency or a primary etiology, and that just implies that it's run garden variety. Genetically predetermined, valve failure, et cetera, that leads to your venous insufficiency. The third part is A or anatomic, and that has to do with what part of the venous system. There's superficial veins, there's deep veins, there are perforator veins that connect the two, and any or all three of them can have, some sort of abnormal functional problems that need to be addressed. And then the last category, the P part of it, is pathophysiology.
Oh boy.
And that has to do with, the underlying, pathologic problem. Is it reflux or is it an obstructive process? Sometimes, probably the most common one is reflux. The reflux is due to the valve failure, and reflux means that the blood's going in the wrong direction.
And gang, we talk about this a lot, and we often talk about legs, and that's because your feet are the furthest part of you away from your heart. So it stands to reason all of these valves and things that are bringing blood back. If there's a problem down at the bottom there with valves that aren't working and swelling, now you really got something that we got to keep an eye on.
And I think that's a good observation because of the fact that the further you go down the leg, the more severe the findings and the symptoms can be, and that's because of what you said. Your feet, especially when we're standing in an upright position, your feet and ankles are the furthest away from your heart and are suffering the greatest impact of that valve failure. So
I tend to be, because I've been doing this for such a long time, my friends, I'm like a little radar guy. I'm looking at people's feet all the time. And I've learned a tremendous amount, not just about myself getting the treatment that you've been performing on me, but also that other people that just put up with stuff. And it's amazing. Didn't you find this? That they justify it. They try to explain it away. Oh, no, that's the sun. That's the sunburn. That's no problem. I just got sunburn.
Sure.
Every day.
Yeah. People rationalize their symptoms.
That's what I meant, rationalize.
Completely, yeah. So, and again, why do we want to use a classification system? Well, it helps us in the fact that it helps us define the severity of the process that's going on in any one person. That's a good thing to know. How severe is it? That implies the second reason then is how urgently do we have to act on that? When somebody comes into the office and if all they have are C1 or C2 disease, is that an urgent problem? No way. Do we run into or get into an emergency kind of operating mode with that? But when they come in and have these more advanced stages, then we feel like we have to be a little more efficient and a little more directed at trying to do something to, stop the process as quickly as we possibly can.
Yeah, and that's the thing that I've learned personally, everybody, and you ought to do this. You can go to veinclinicsofhawaii.com anytime, veinclinicsofhawaii.com, and enter a question, and we'll answer it on the show. We do that. It's called mailbag, and we'll do that. Maybe next time we'll do another mailbag show. In the meantime, you have to rest assured that everybody's been there, and Dr. Julip's guys have all done that. And that's why one of the things that I was the most concerned about, and I did it like everybody else, and that was what we're going to get into sooner or later, and that's what does it look like on the outside? What can a layperson learn from what? What's that? What are all those brown spots? What's this all about? Why don't I get that looked at?
Right, yeah. So, a couple of other reasons that I wanted to mention about the Seep classification is that it helps us, track the response of people, which I think is very, very important. One of the things that we didn't do very well in the past, back when we didn't have all the newer technology that we have these days to treat venous insufficiency, is we didn't track people very well. And this is probably even back before the Seep classification was, in place and being utilized. Yeah. But when a patient comes in, we find out where they are on the Seep spectrum. And then, we go through their treatment process and we follow them over time, and we want to, make sure that we are seeing improvement. And if we keep track of that Seep system for each person, for every time they come into the office, we can see that, yes, our therapy is working or it's not. Hopefully it's, working most of the time. And then the other thing that we can do is to utilize that tracking process and also that designation of the Seep system with respect to larger systems. When we're studying large groups of people, how statistically how are people moving within the Seep system according to specific therapies that we're giving them.
By the way, this system Doc's talking about is only a couple of decades old, and it's accepted and relied upon globally. Oh, yeah. And that's what's so exciting about it in some respects, that if you have venous conditions going on, my friends, that are bothering you, and you haven't acted upon it because you have this level of fear, when your mom or your dad had it, those things go by the board, because all the procedures that I've done, and I've had a lot of them, I walk in, I walk out. No hospitals, no missing work if you need to work. Of course, if you can take a day off, it'd be nice. I did that one time. But seriously, I think that it's not that it's fun, but it's predictable. I mean, what you're doing now, once I've got these things going on with me, and you can identify what there are, boy, there's a clear path to victory on this stuff. In many cases.
Yeah, right. I think that especially again over the past 20, 30 years, we've learned so much about how we can treat the disease process very, very efficiently and do it with a limited physiologic impact on the patient, not a lot of trauma with respect to the procedures that we do, and most people get through it very, very easily and are very, very happy with the result. But so last week we talked about the first three clinical levels, 1, 2, and 3, and we said that C1 are those people with spider veins, and sometimes those people have what we call significant venous insufficiency or underlying functional problems with the venous system. Sometimes they don't.
Sometimes they don't. That's
sometimes
good.
It's just
the lucky ones don't.
Yeah,
I wasn't one of those.
Right, exactly. And so in those people, they come in and they have no symptoms of venous insufficiency, and they don't maybe have a strong family history. And we say, listen, we may not even do an ultrasound in those people. We'll just treat you from a cosmetic standpoint.
Sure.
That's what those people are looking for. They want their spider veins treated, and we can do that very easily with injection sclerotherapy.
I got to interrupt. This is something that happened the other day. I was at a store, and a listener asked me if they can buy a gift certificate to have spider veins for their daughter, who is a swimsuit model. Okay, and I said, you know what? I bet there is, because this is something that, I mean, you may not say, here, give me $4 worth, but isn't it interesting that some people want to do that because maybe their significant other or their daughter, their son, either doesn't have enough money or is just too embarrassed to ask or just feels bad. What a nice thing that is. Has that happened? When somebody says, you know, say, I want to have my wife come in. You're treating me for a deep vein thing, but I want to have my wife come in for some spider vein stuff. I want to treat her. Yeah.
Sure, we get that. Yeah, absolutely, yeah. Because, you're right. I mean, especially if it's a younger person or whatever, they, may not have the...
swimsuit model. That's pretty nice.
Yeah. Lord have mercy. Yeah. That'd be a stressful procedure.
Yeah, I should say.
So anyway, so that's C1, that's spider veins. C2 is varicose veins, and we talked about the fact that, once you move from C1 to C2, it's a little more likely that you do have that process of venous insufficiency. By virtue of the fact that you have varicose veins, that would kind of imply that, there's abnormal flow and abnormal pressure and all that sort of stuff within the venous system. That's how those more superficial veins dilate. And, typically it's due to valve failure, which is the most, common problem. And, so in last week we also talked about the question of, should people with varicose veins be evaluated? Should they go to the vein doctor? And again, I tell most of those people,
I do all the time.
You probably need to because, there is a very strong likelihood that you have underlying venous insufficiency. There are there are a number of negative repercussions that can arise from that. And depending on whether you have symptoms or not, which, sometimes people don't really recognize the symptoms that they might be having. We've talked about the fact that, the symptoms of venous insufficiency, they come on over such a long period of time and so slowly that you just kind of get used to it, or you chalk it up to other things, like we talked about a minute
Sunburn,
ago.
Forget it. Sunburn, you have a problem.
So I think most people need to be evaluated for varicose veins. We at least we can figure out again where they are on the Seep spectrum, and we can make decisions accordingly. Even if all we do is conservative therapy, with compression stockings and periodic ultrasounds to follow what's going on with them. And then C3 was or is edema. And, those people that have swelling in their lower extremities, they have their own classification. It's called C3. And I look at C3 as kind of moving from, the lower levels of the disease process, C1 and C2, where, you may or may not have symptoms. You may have symptoms that you're not, that really are not altering your lifestyle. But once you move into the C3 spectrum, where you're starting to develop swelling in your legs, especially if it's if it's related primarily to venous insufficiency, then that tells us that it's a little more important. And again, it becomes a little more. There's a little more urgency. I mean, it's not an emergency. Don't get me wrong, but there's a little more urgency in saying, "Gee, what's really going on here?" Right. And in people with swelling, do they need to be evaluated? Absolutely. We need to figure out why they have swelling. Now, there's a whole host of reasons why people might have swelling, but again, venous insufficiency is one of the very common ones. If they don't have other major medical problems, and it's easily figured out with an ultrasound.
Yeah, and by the way, the ultrasound treatment is what makes it possible to have this stuff done. Just with so little invasiveness. I mean, it used to be if Auntie had to go to her vein stripped. Oh boy, I mean, those days. I mean, that was like high button shoes and stagecoaches. I mean,
Well, and before you mentioned an interesting point, and that is, how did we figure out how did we diagnose venous insufficiency before we had ultrasound? And we did use other things, and some of them were very invasive. and complications and all that sort of thing. So yeah, ultrasound has been a godsend, and yeah, it's totally non-invasive. It's completely pain-free, and
amazing.
it gives us such a good picture of what's going on inside the leg. So, so moving on. So today we're going to talk about C4, 5, and 6. Those are the other three. And these are definitely a little higher level, a little greater magnitude of, venous problems, a little higher level of venous disease, a little more urgency in, defining exactly what's going on and figuring out how we can stop it.
Exactly.
We'll treat it and stop the process. So C4 basically means that there are skin changes. We use this term skin changes. And skin changes have to do with a number of different things that we're going to talk about. But the C4 level of the clinical part of this classification is the only one that's divided into two subsets. C4A, C4B, and again it implies C4B. The things that we see in people that are in that classification section, it just implies a little greater problem that's going on, a little higher level of venous insufficiency and its repercussions. So CA is basically what we call hyperpigmentation. And the other thing that we see in C4A is something that we call venous eczema. So what is hyperpigmentation? Well, basically it's just a brownish discoloration that we see in the lower part of the leg, down around the ankle and typically ankle mid-calf, mostly on the inside of the leg, although it can be all the way around. This discoloration, again, it's kind of like the first indicator of bad things going on.
Here comes a big sign from somewhere.
Exactly. And unfortunately, hyperpigmentation is one of those things that people who have it attribute it to, a lot of other things.
I'm guilty.
Yeah.
Sunburn.
Right. Being out in the sun, diabetes, other health issues, heart problems, etc. And so often it's due to venous insufficiency. Now, the problem there is that it's not that intuitive. I mean, it's not obvious unless you've been told by someone that, that brownish discoloration in the lower part of your leg, it can be due to a circulation problem that we call venous insufficiency. You're not going to know. And a lot of people are not told that.
Yeah, and I'm really curious about that because I've asked this question before. And by the way, speaking about that, even though you're listening, there's 6 different classes of venous insufficiency and disease. There's a myriad of stuff to be learned on the website, veinclinicsofhawaii.com. And there's also a way to contact us at veinclinicsofhawaii.com to get questions answered or something on the show, because I do know that one of the things that you look at is that a lot of times somebody thinks they have a dermatology problem. They go to a dermatologist. And quite often a dermatologist will get to a point where they're trying to evaluate or treat somebody when they decide, you know what? This is not a skin problem that you have. Mm-hmm. This is something that's going on in your leg. You need to see a venous guy. And I know there's a lot more interaction between the professions and specialties than there used to be.
Yeah. We get a lot of our patients from dermatologists, for sure. And they will either, a number of them will say, hey, listen, you've got venous insufficiency and, go see these guys. Or they will treat them like, routine eczema or other, rash kind of things. And it goes away and comes back, or it doesn't go away, or just doesn't respond the way they expect it to. So they are then, entertaining the idea that there must be something else going on. And then the patient eventually gets to us. And
so you got to rule out a lot of things on the way to really determining what's wrong with me and that color of my leg.
Sure.
It could be a number of things.
Right.
Yeah.
So that's hyperpigmentation, and venous eczema. Basically, it looks like eczema. It can be dry, it can be flaky, and again, it's just one of those things that the constant, venous, what we call venous insufficiency, venous hypertension, the ultimate effect that it's having on the skin is that it can result in an eczematic kind of rash that looks like a routine eczema. So that's 4A, hyperpigmentation and that venous eczema, or what we call stasis dermatitis. So the C4B is then something that we call lipodermatosclerosis.
Oh boy.
No,
I'm glad you're here because I would have had trouble with that one.
Word of the day, lipodermatosclerosis, and then something also called atrophy blanche. So what is what is that all about? Well, that also has to do with chronic inflammation. And basically, lipodermatosclerosis is thickening of the skin. As the disease process, as venous insufficiency goes on over a long period of time. Again, it affects the leg in a lot of different ways, but ultimately it's going to affect the skin, and it just the slow progression then ultimately leads to hyperpigmentation, and then kind of a fibrotic change within the skin itself. It's almost like a scarring of the skin, but it becomes thickened. It becomes leathery. The surface is very irregular, and that's what we call lipodermatosclerosis. This atrophy blanche is something that we see in some people, and it's actually white patches that we can see on the skin.
The white little white patches.
Yeah. They're not, usually it's not a large area. Usually it's just like these little stellate areas that are white, kind of smooth and glistening, and basically that just has to do with the fact that because of the venous insufficiency, the venous insufficiency has gotten so bad that it has affected the blood flow, the arteriolar kind of blood flow into that area of the skin, and basically there's no arterial blood flow, and it turns into a whitish pale scar-like kind of little stellate portion of the skin, and we call that atrophy blanche, and that's just another sign of fairly advanced venous insufficiency.
So it sounds like you may not be, having a treatment for that specific thing.
No.
But you sure can prevent the adjacent property going bad.
Right. Exactly.
That's a new way to put it.
And that's what I tell people. I mean, unfortunately, with hyperpigmentation and many skin changes, even when we treat the underlying venous insufficiency, it usually doesn't go back to normal.
Yeah.
Unfortunately, the brownish discoloration hardly ever goes away.
Yeah, and that's why I'm living with that on my ankles. But I can tell you, it does get a little bit better. I mean, it doesn't look sore. Some of it, especially when it's red, boy,
right.
That must hurt.
Right.
I don't know. Yeah.
So what do we typically see? Well, people that come in, they might start with just kind of very mild patchy discoloration, and and we see people come in at all of these different levels.
Sure.
The early stages of C4A, when they're just starting to have darkening of the skin. It can be very, very patchy. It can be kind of very limited areas, but as time goes on, it becomes, broader areas. As time goes on, they can develop, this stasis dermatitis. Not everybody develops that, but, many people do. Then the discoloration becomes even more diffuse. And, again, like I mentioned before, sometimes the entire lower leg from, the upper calf on down can have this hyperpigmentation. But as the discoloration progresses, then the skin starts to thicken, inflammation increases, and then the skin has this, we call it a cobblestone kind of appearance. It's kind of a progressive process that ultimately leads to skin breakdown, which we'll talk about here in a little bit. Why does all of that occur? Well, it occurs because skin in the system, the skin is sort of the end organ that is seeing the negative aspects or negative events that is caused by ongoing venous insufficiency for a long, long time. And what is that? Well, what happens is that the reversal of flow leads to not only blood kind of pooling in the lower leg, but it also leads to a higher pressure system within all of the venous system, and that's something that we call venous hypertension. When we talk about people having high blood pressure or hypertension, that has to do with the arterial pressures within our heart and blood vessels, and that's kind of the routine thing. But abnormally high pressures within the venous system, especially in our legs, can also occur, and that's something that we call venous hypertension. So, what happens is that as that venous pressure becomes higher and higher, and over a longer period of time, the tiny veins within our skin then become leaky. The actual, the cells making up these tiny little, veins and tiny little venules, start to separate, and things start to leak out that shouldn't. One of the things that leaks out are red blood cells, and red blood cells have molecules in them that carry oxygen, but they're those molecules, and what those molecules break down into are basically pigment molecules. Okay. So it's almost like tattooing the skin. You're putting a pigment into the skin, with the we call it hemosiderin deposition, and with that process, the pigment is coming from the inside and going out, as opposed to a tattoo the other way.
Yeah, but the interesting thing is, people have asked me about this, and they said, your skin is an organ, right? And it keeps growing. Yeah. It keeps growing and growing. But what we're talking about is certain parts of that skin don't function anymore. In other words, if you have nice, clear-looking skin all over your place, look at the billions of dollars that people spend every year buying concoctions and creams and ointments and everything, thinking it's actually going to make a change. Some of it can be very good for certain things, but I mean, as yet, anybody in your business developed, here's a cream that'll make that skin come back and be nice?
Yeah, unfortunately, no.
Yeah, it's not gonna, but the quicker people learn to deal with that, isn't it a godsend when they finally find out, number one, what it is, and number two, one way it looked, but it also had some other issues, maybe pain, maybe itching, maybe burning. And by getting treatment, some of those things will be mitigated and go away.
Right, yeah. So, and that's the crux of it right there. Learning about this early, acting upon it early, so that people don't get to that level. And again, it kind of goes back to the fact that most people don't know what these signs mean, unfortunately, and that's one of the reasons why we do this, is to try to
that's why I'm here. I know that.
Try to educate people and to give them the knowledge that they need to make good decisions about their overall health, especially their vein leg health. So anyway, so the leaky molecules in the blood cells and whatever that are going from the vascular space into the skin creates inflammation, and basically that's the bottom line. There is it's chronic inflammation of the skin that leads to all those things that we talked about before. Do some people have it worse than others? Yeah, it's sort of on a spectrum.
Sure.
And what does that do to? I'm not quite sure. It's probably the severity of the disease, the chronicity, the extent, how long it's been around, etc. But for sure, the longer that the chronic venous insufficiency goes on, the more likely you are to develop these advanced skin problems. And we see this type of process, especially in people that have had DVT in the past, deep venous thrombosis.
By the way, I do get asked about that a lot, Dr. Juliff, and that is once somebody's had a DVT, and they see a lot of advertising now that you can take certain medications and reduce, but not necessarily clear the decks.
Yeah.
Because once you have it, doesn't that mean that your body did this for a reason? And it's probably going to do it again. You got to really keep an eye on this stuff.
You do. People who have a blood clot, their risk of having another blood clot just by virtue of the fact that they had a blood clot.
Sure, yeah.
Whether there was a reason for it or not, they're at a much greater risk of having another blood clot, and it's something that they need to be aware of for sure, and respond to limiting their risk. Especially in various situations, but. So anyway, DVT can be additive to this whole process. People who have DVT then often develop deep venous reflux or deep venous insufficiency, and when they have deep venous as well as superficial venous insufficiency, it's an additive kind of problem and makes it that much worse. Sometimes we see the skin gets so bad that not only is it real thickened and fibrotic, but it can actually we can actually see fluid sort of weeping from the skin sometimes, and that's not an uncommon common occurrence when people are first coming into our office.
But gang, I got to tell you this, and this is interesting because I know there are some of you out there that do this. It can be that you keep putting a Band-Aid on something for a long time and it doesn't go away. We're getting into that part of it a little bit later. But that is a clear sign, right? I mean, if all of a sudden you got a wet leg all the time, that's not supposed to happen.
No.
And so I guess if you didn't hear it on a show like this, or if somebody in your family didn't tell you, these are clear signs that too often go ignored.
Mm-hmm. Right.
Yeah, very clear.
Yes. Yeah. Yeah. Exactly. I mean, there's any number of people that we see that that can have bad swelling and skin problems and weeping from the skin, and they can kind of put up with it for a long period of time. Sometimes it's surprising, but ultimately they get to us, and better late than never. But we can help that immediately. There are things that we can do nearly immediately to resolve that real severe swelling and limit or kind of control the fluid accumulation, which will then get rid of the weepiness and the crusting and all the stuff that we see. So does this happen to everybody? And the question there is, some people might be saying, gosh, I have venous insufficiency and I have varicose veins and I've had that treated. Does that mean that I'm going to at some point get to the place where I have skin discoloration and the thickening and the lipodermatosclerosis and breakdown and all that sort of stuff? Well, the good news is no. Not everybody that has venous insufficiency is going to get to these higher stages. It's about 20% of people with venous insufficiency over a long period of time that will get to these higher levels, these C4, C5, C4A, B, and then onward up to the
and I know, gang, because I'm getting to be one of the old dudes. I know that this is something that's happened to me through no bad things. I mean, none of this. Nobody wants to put this on on purpose. But when it does happen, that's why we talk about these classes that we're doing, these 6 different types, the six different classes. As you can see, what we're talking about now is not going to happen to everybody, but if you are one that tends to go that way, and I say this all the time, you go to veinclinicsofhawaii.com and get on the hit parade because, Doc, one of the things, it's like any disease or like any medication, any specialists that you go to see, the quicker you determine that I've got that thing, the better it is going to. And you talk about this all the time. It's all about quality of life. That's the whole deal.
Right.
It's not cosmetic. At this point in time, what we're talking about is life-changing.
Oh, definitely. Yeah, definitely. I mean, general not only leg health, but your general health and also, quality of life. Yeah. Absolutely. So, what do we do? What is our modus operandi? How do we approach these things? Well, first of all, we do, a complete evaluation. Patient comes in, we take a full history and family history, and there are other medical problems,
sure.
which is always very, very important. We examine their legs, which again is such an important part of the evaluation, because most of the time when somebody comes in with these types of problems, I mean, really all it takes is one look at their leg, and we can kind of say, oh yeah, I know where that person is within the Seep classification. But so then the most important, or one of the more important things, is to do an ultrasound, and we do that pretty quickly after the patient has come into the office, and in that way we can define exactly what's going on. Do they have superficial venous insufficiency? Do they have have they had a history of blood clot? Do we see residual problems? Do we see residual blood clot in their veins? Sometimes we see that. Sometimes we don't see a blood clot, but we see the ravages of that blood clot having been there, which is a lack of valve function in the deep venous system, and significant deep venous insufficiency in venous reflux, which again kind of worsens the scenario even more.
To me, it's interesting because this system that we have, this venous system that we have, when you talk about deep, it's amazing how deep it is. And that's another thing we've talked about a lot. And when you talk about ultrasound treatments, which I've had recently, it's really easy to see the ones on the top. Mm-hmm. But you got to have a pretty good operator to really get in there. And some of it's a little harder to see than others, right?
Oh, yeah. Yeah, definitely. Yeah, definitely, especially when people come in with a lot of swelling.
Yeah.
The swelling kind of interferes with our ability to get a good ultrasound picture. But most of the time, that being said, most of the time we can figure out what's going on. So, are there things that we can do immediately? Yeah. When we have people come in with a lot of swelling and, the skin getting on the verge of something really bad happening, is it important to immediately do an ultrasound and then immediately talk about doing procedures and all that sort of stuff? No, it's not. The first thing that we have to do is, control that swelling, especially if we have somebody who has, real bad skin, is on the verge of, breakdown. Those people who are, having fluid weeping from, through the skin, we need to do something more immediately about that.
And I do have a question about that. And gang, if you have a question, it's easy. Go to veinclinicsofhawaii.com. Dr. Julip's gang will categorize it right, and we'll get it on the show. And all 4 islands, we got Big Island, Kauai, Maui, and here on Oahu, veinclinicsofhawaii.com. And I think the interesting thing about that is that, and we've actually touched upon this before, sometimes somebody has got one of these symptoms that is so severe that you really can't go in there and operate because you need to control that first. So maybe that's
right.
Isn't that a huge step in the right direction?
Oh yeah. There's many people that we sort of put off doing interventional things until we stabilize what's going on more superficially. The first thing that we can do is some form of compression, and I think that a lot of people, when we talk about compression or compression stockings, they kind of go, what is that going to achieve? But it's just
a lot.
A tremendous amount, a tremendous amount. I mean, when you see people who come in and just have huge legs, and we start some sort of compression wrap system for them, and it can clear up, not 100%, but it can clear up substantially over a very short period of time, and it's remarkable, really.
Yeah, and by the way, gang, we talk about your lifestyle, we talk about your enjoyment of life. Sometimes we're just talking about working. I mean, can you imagine if you got this swole up leg every day? You're not being very good at the office at the end of the day. You're kind of a cranky old guy or gal, and you need to get that stopped, and that's what some of these things will do. But I do know it's every now and again if you have a bad infection going on, and you're going to have some surgeon will say, well, we're not going to do your eye today because you got a bad tooth.
Sure.
Or we're not going to do your leg today because you got swelling.
Yeah, well, swelling or infection.
Yeah,
sure.
both. Yeah.
That sometimes can be a part of the problem too. If there's infection, then obviously we're going to want to treat that with antibiotics and stabilize the skin from that standpoint too. But compression we use instantly, immediately. That patient is going to leave the office with some sort of compression. Right. And then the other thing that people sort of minimize is elevation. Yeah. We talk about elevation, and I talk about elevation till I'm blue in the face, and because people resist it. But elevating periodically throughout the day. If you really have somebody with severe swelling issues, there really needs to be addressed immediately. Compression along with elevation. Again, it can make tremendous inroads. So elevation, even though it's it's not a drug, it's not an antibiotic, it's not a procedure, but it can be so useful and so beneficial.
It's part of the tools.
Yeah.
It's part of the little magic fix bag Dr. Julep has. And look, some of these things are really simple. I was kicking like a mule about wearing compression stockings until I started wearing them. And what's the big deal? I should have been doing this 20 years ago.
Yeah. So, and then there's something that we call Una boots, and Una boots are not an actual boot. They're a medicated wrap. We use a lot of that, and it's a specific form of compression, and it's something that the patient doesn't take off. They we put it on, they leave the office and come back in a few days, and then we reapply it, and it is so tremendously useful in some patients, in some settings. Again, treating acutely that swelling in the fluid management process. It really can be very, very remarkable, and we use that quite a bit.
And it's sort of interesting now because it's a whole new category of surgery available, particularly when you talk about all of the experience that you've had recently, and a lot of your peers, and that is these wound centers and these places that are really it's a venous issue, but it's way past that when they have to go to that wound center because it's a real big hole, big problem.
Right. And then the other thing I wanted to mention is along the lines of compression is something that we call sequential compression devices, and sometimes we utilize those. Those are a little more cumbersome and a little more inconvenient for the patient to use. But with respect to wound care centers, we utilize them all the time because at the same time, if somebody comes in and they have real bad skin problems or breakdown, we're going to be doing our thing with them, and we're going to be doing our evaluation. But at the same time, we may be sending them to a wound care clinic so that they can do what they specialize in.
And gang, here's where I have to throw in, because Doc and I have talked about this on other programs. And by the way, there's a myriad of other programs that you can access on veinclinicsofhawaii.com too. So Dr. Julep and I, we do these shows and then they go up on the web later. But I think that one of the things that is really, really cool about it is that when you get into that wound care, and when you start trading off with other professionals, now there's a real team that's working on you. And I think that gives patients a lot of something to look forward to. But here's the thing that always amazes me, and I've got to ask this question, I always do. I am blown away when you tell me sometimes how long people will put up with a condition or a hole in their leg or a wound of some kind and thinking it's going to change, and it never, ever does.
Yeah. It is, it's surprising. And again, I think here it goes back to that people just don't know. They don't know that there are, the types of things that we do that can alter that process so dramatically. But we see people that come in with ulcers all the time that have had them for months, if not years, and they'll be treating them at home, and even they might be treating them along with a physician or a practitioner, and they might get them healed. But the problem with venous ulceration is that if you don't take care of the full problem,
there's somebody in the back of that thing knocking on the door trying to make another ulcer.
Exactly, because it will recur. I mean, recurrence is the problem, and so that's why it's so important to our immediate goals are to treat the swelling, to treat the acute skin kind of problems that are going on, and then to evaluate them fully for venous insufficiency. Ultimately, we are going to be getting around to, doing the interventional things that we do to try to optimize their venous function. So that's all C4, and again, it's two subsections, and again, as we're kind of going up the ladder, the number is getting a little higher. So what is C5? Well, C5 in this classification, it's kind of funny when you think about it. C5 should actually come after C6. It should be 4, 6, and 5, because basically, C5 is the classification of people that have had an ulcer. But it has healed. So we refer to them as having had a healed ulcer. So that's important to us. They had an ulcer in the past and it got healed. So that's a classification. Is it worse than 4? Well, yeah, it's worse than 4 because, that patient actually went to 6 and then either through local care or maybe they went through, venous procedures or whatever. But
got lucky for a while.
Or got lucky for a while. The ulcer has healed. So it indicates, again, a little higher level, a little more chronicity of the problem, a little more severe, subset if they haven't been treated already for their venous insufficiency. So is it worse than stage 4? Yeah, it's worse than stage 4, even though the wound has healed. But many of these people have gone through, again, wound care clinics, and they've been treated, again, superficially for their ulcer, and they've been able to heal it. And sometimes that happens, and sometimes it stays healed, and again, the patient gets lucky. Sometimes it doesn't. It recurs, and then at that point, they kind of get to us, and then we can evaluate, their venous system. So C6, the highest level, basically, that implies that they have an active ulcer. So they've gone through all the other stages, and especially the C3, swelling, then the skin problems, then ultimately leading to ulceration, and sometimes this happens spontaneously. Sometimes the venous insufficiency and the skin problem just, progresses more and more with time, and the skin ultimately breaks down, maybe gets a little crack in it or something. And ultimately, that doesn't heal, and then that turns into a much bigger wound. Often people will describe some sort of trauma to the leg.
Sure.
So they have these ongoing venous disease, and they have this ongoing skin problems, and then they are out working in their yard and they bump it on something, or they knock it against a coffee table. Or it doesn't. Sometimes it doesn't take much.
Yeah, I'm telling you, dang, that's what happened to me. And,
right.
And the part that I was very grateful for, and before we run out of time, I got to tell you this, that when you all of a sudden find out that, hey, you're not the only person with this. This happens all the time. But people don't understand in time that they got to go to veinclinicsofhawaii.com and look into this, because if you got a hole that's not healing, it's probably an ulcer.
Yeah.
Because it doesn't, the word ulcer just means a hole.
Yeah.
So some are pretty big.
Yeah. Yeah, and ulcer just means breakdown of a surface, basically. We talk about, or people know about ulcers in the stomach and in the small bowel, duodenal ulcers and all that, and that just means an erosion of the inner lining of the stomach. Same thing here; it's an erosion of the skin, and it often implies, specifically, that there's a problem with the perforator vein. And we mentioned perforator vein just quickly before. Perforator veins are a connection between the superficial and deep system, and they are veins that were very, very difficult to treat in the past, but we have, again, minimally invasive procedures nowadays that can even take care of that kind of thing, which makes treating ulcerative disease connected with venous insufficiency that much easier.
Okay, and gang, that's exactly where we're going to end up. That's the end of the line in its category number 6. And if you're there, you need to get treated. And there's certainly a lot of options, and we want you to check that out at veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. And this and other episodes are available online. And if you'd like to ask a question or make a comment or get something heard on the show, it's pretty easy. Just go to veinclinicsofhawaii.com and click on, send a message and get a message. So thank you so much for listening. And next time, we'll probably get together and do one of our mailbag shows. And that was where we get some of your questions actually answered. So thanks for listening. And for everybody at Vein Clinics of Hawaii, we'll see you next time. And remember, keep those legs going. You only got a couple of them. You got to treat them well.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.